and Councillor Van Dyke, who has taken Councillor Adaway's place. She's been a good member of this committee, and I, for one, will miss her. That takes us on to the record of the meeting. Is everyone happy that it's a true record of the meeting? Yep, thank you. I have no urgent matters to announce. Good evening. That takes us on to disclosable pecuniary interest or other significant interest and whipping. No, are there any declarations? No, thank you. That takes us on to agenda item 5, long COVID update by Rachel Paris, Deputy Director of Health Improvement and Transformation. So over to you, please.
Lovely, thank you very much, and thanks everyone for asking me to come and give you an update. So I'm going to make the assumption that you'll have read the paper. I'm just going to pull out some of the key highlights and then very happy to take any questions or points for discussion. So I think we came to the committee 6 months or more ago. I think initially it was my colleague Abby that came originally. So I'll give you a little bit of an update. So we know long COVID is a new and emerging condition which can have a significant effect on people's quality of life. So it's known that around 1 in 12 patients can find the recovery difficult after COVID. And although many people do get better in the first 6 to 8 weeks after illness, there are a number of patients that continue to struggle after 12 weeks post their COVID infection. And that's the point at which we say that someone has long COVID, potentially. There's an evolving evidence base that continues to grow in relation to best practice and also identification and care for patients, although we do know from the most recent scientific evidence and papers that it is the approach to care is that of one that works towards recovery rather than long COVID necessarily being a long-term condition for the future. So we're required as an ICB footprint, obviously, to provide and ensure that there's an end-to-end pathway for patients with long COVID. And there's lots of guidance nationally, either by NICE, which suggests the clinical guidelines for looking after people, but also NHS England and other guidance around what services should look like and the services we provide for people. So national estimates remain experimental, but 3 to 11%. And we are seeing an increased prevalence, highest in females between the age of 50 and 69, people with pre-existing health conditions, and also those that had a high viral load at a time of infection, so if you got it quite badly. What we are seeing, though, is that if you're double vaccinated, you're showing a reduced risk of long COVID, around 49% lower than were in those that are unvaccinated. So there's some key principles of care for long COVID that you won't be surprised to hear. They're key principles of care for many things around personalised care. I think particularly in long COVID, listening to people and asking what matters to them and providing them with a personalised plan of care. A multidisciplinary rehabilitative approach for people. The symptoms are both physical, mental and social, and supporting and enabling people to self-care and look after themselves. So we've had a strong emphasis in Kent and Medway on finding out people's experiences, and I think particularly as it's a relatively new, it is still a new condition. The science hasn't really caught up yet. And evidence in terms of what we should be providing for people. So it's really important that we actually listen to the people that we have locally that have long COVID and find out what would help them and their families. And we've involved them at every stage of the development of the services, as you can see from the paper. I'm also pleased to share that our engagement work with patients around long COVID has been recognised nationally, and we actually won a National Patient Engagement Award for the work that we've done with people with long COVID. Now, that doesn't mean to say we've got everything right. It means that we continue to work to provide the services that are needed, but what it does mean is that we are engaging well with the people who have the condition. So the post-COVID service has been up and running since May 2021 now, has received 2,500 or more referrals, and it has the capacity within it to meet the demand that's coming through. Our local service sits around national average for wait times, and actually we fare slightly better than our peers across the southeast. We're looking to completely eradicate this year waits that are over 15 weeks, and actually we only have a very few at the moment, with the aim of working towards a 6-week wait for all referrals. That is, of course, dependent on whether we continue to have further waves of COVID, which, you know, cause additional demand for the service. So I think the last thing I just wanted to add is some work around reducing inequalities. Due to the challenge in determining the expected prevalence, we've taken a health equity approach to that. So we're looking at local population and what we're seeing as demand coming through to the service. And I've included some of that for Medway and Swale within the population. And I think you'll see that there or thereabouts, we are seeing the profiles of referral broadly match that of the local population, although we continue to work to do some targeted, in targeted areas where we need to. So I think I'll just open up to questions, if that's okay. Happy to add anything or answer any questions.
Yep. Thank you very much. Members, Councillor Murray.
Thank you very much, and apologies everyone for being a bit late. There was a little incident on Dock Road when I was coming along. Thank you for the report. I wanted to talk about a few general things and then some specific things. The number of referrals, I think, is quite low compared to the number of infections that we've had, and I wondered if you had any comments on that. Would that be because there's just only a small number of people suffer from long COVID, or is it about a failure to recognise symptoms, or is it that at the point that we have started to offer a treatment pathway, in fact, there are more people who've been vaccinated and therefore fewer people likely to suffer from long COVID. So sort of one of three there. It says a lot about the engagement that has happened. And I wonder if associated with that, and perhaps because I haven't seen this or been aware of it in primary care, whether there's been any sort of a programme to encourage the public to recognise the symptoms, because they're quite general, aren't they? Sort of post-viral symptoms, some of them, not all of them. And I can imagine that some people might get a mistaken diagnosis. When someone goes on the treatment pathway, I'm sure it is individualised, you've said that, but I wonder how long you might expect them to remain on that, and whether within the pathway there's a step-down process that might, for example, include some social prescribing. And thinking about the situation now, it seems to me that there are still lots of people getting infected with COVID, actually, and being quite ill, regardless of, certainly in my employment, within our labour group, we've had people quite poorly for 3 or 4 weeks after being infected with COVID who've been triple jabbed. So I guess there's still quite a lot of work going on to establish how the different strains might develop. And as a result of that, I wonder if you're doing any work on the economic impact that there might have been in terms of people being unable to be economically active or less economically active than they were before they were infected. And finally, there's a little bit in here about reducing inequalities, but I suppose I expected to see a bit more about the extent to which long COVID affects different groups within the health inequalities picture that we've got. In other words, we knew before we ever heard about COVID that people in more deprived areas are more likely to suffer with respiratory illness and heart failure and cancers. And I wonder if those groups have been impacted more by long COVID. Thank you.
I'll take those one at a time. I'm glad I brought a pen. So in terms of the number of referrals coming through to the service, I think it's safe to say that some people that experience long COVID or symptoms for more than 12 weeks will have very severe symptoms that warrant a specialist referral, and therefore they might go direct into secondary care to a specialist in whatever it is that they're doing. There'll be a cohort of patients that also continue to have symptoms but are quite a mild level that don't necessarily require any intervention. So there's probably quite a big cohort of the entirety of people that have symptoms for more than 12 weeks that actually can be managed with self-care. And then there's kind of the cohort in the middle, which are the ones that we're seeing coming through to the post-COVID assessment service. So they're more likely to be people with moderate symptoms, with a number of symptoms that perhaps require multiple interventions and an assessment to really determine what the best intervention would be for them. So I think we are only seeing kind of a small portion within the post-COVID service. In terms of engaging with public to recognise symptoms, due to, I think, the fact that we were a little bit behind the curve, which is probably what you discussed when my colleague Abby was here last time in setting up the service. We have done a limited amount of public facing work other than the engagement work with patients in terms of raising awareness of symptoms in particular. We have been advising people, however, to go to their GP and to primary care as a first port of call. And there's a number of reasons for that. As you've already outlined, the symptoms of long COVID are very similar to lots of other symptoms and are very general. And post-pandemic, there are many people coming forward with symptoms similar to those that actually primary care and the person's GP needs to ensure that they've excluded other conditions before referring on to the post-COVID service. So I think my answer is we haven't done any general public, do you have long COVID publicity, but there has been, I think, a significant amount of public awareness raising around attending their GP with symptoms that they've had during the pandemic and after the pandemic to determine what that might be. I don't know whether that answers your question, but I think it does. In terms of how long people remain on the pathway, it's really differing. There are some people in our reference group that have been experiencing symptoms for over 2 years now. They got it right back at the beginning when there wasn't vaccination, etc. But many people go on to recover. So I think it's probably, there's no set determination around how long someone stays on the pathway. Someone may require some physiotherapy intervention, for example, or some vocational rehab, which kind of links to your economic question, actually. But they may need a small amount of self-management support linking into social prescribing and peer support groups which are available in each area in Kent and Medway. So it's very different, it's very individual for each person. And then in terms of your question around economic impact, no, I don't think we've certainly in NHS Kent and Medway not done anything specific around the economic impact. What we do know is that many people continue to remain off work. It is something that's assessed as someone's referred through to the service, and it is something, one of the interventions, as it were, that's provided, or support that's provided. So there is vocational rehab support within the service in terms of support with liaising with people's employers, supporting people to get back to work. And then your final question was around differing groups and the inequalities. And yes, it is the usual suspects, as it were, I think, that are particularly impacted long COVID. So those that are with an existing long condition, those from particularly deprived groups, and those that weren't vaccinated. But you're absolutely right around the people are still getting COVID. They're still getting COVID quite badly, and actually the evidence is showing that transition into long COVID is different depending on the vaccine, well, not the vaccine, sorry, the strain. We're not seeing a decline in the numbers of people coming forward with long COVID, and although it's very easy to say, oh well, you know, after two doses of vaccine, your chances of long COVID are cut in half, we're seeing so many more people getting COVID that actually I think that's why we're seeing still a steady rate of people coming through, and that isn't actually reducing because the denominator is so much bigger.
Okay, thank you. Are you happy with those answers, Councillor Murray? I'll take it you are. Dan, over to you.
Thank you, Chair. It's only following on just briefly from Councillor Murray's. It's only a couple, 2 or 3 questions, Rachel, don't worry. The first one, when your colleague was here last time, she did promise really nicely that she would engage with the VCS, with the voluntary sector.
Yep.
Yeah, because I know I harp on about it here, but they are a really good vehicle to get the message out. And it's following on from the health inequalities point that Councillor Murray made. I think the symptoms of long COVID are changing all the time. There's add-ons. For example, I read today that it's now muscle aches in the muscles is another symptom. And those particularly, and in other areas, but those particularly in our deprived areas, with the education, with being able to access, you know, different various means of communication from you guys, they may not even know they've got it. And I do know in certain areas, as this committee does, people can't get a GP appointment. So they may not be able to go back and get that diagnosis, or go back and get it very quickly for you then to get a referral. So I'd like to know what is being done with the VCS and engaging with them locally to actually get that message out. I'm not saying you want to have another load of hundreds of referrals, but there's probably people in our communities that are hidden, walking around with long COVID that you know nothing about, and they don't know of your service. So that's a key point. And another point is that I'd be interested to know whether you're doing any work or looking into the future outcomes of long COVID, because they're saying it could be linked with, it could lead to ME, or it could lead to fibromyalgia, and it could have really big debilitating impact on the patient, which would then lead to that people being off work for longer, et cetera, et cetera. I'm wondering if he was actually looking at that in Kent, because I know they are elsewhere in the country. I was wondering about that. And the other thing about the different ways of engaging, like video engagement with a patient, and what's the benefits and the impact of that. Because when I look at all of these things, I look at all the different pathways, and I think they're great, and you see it's all lovely diagrams, but it's about actually the real initial impact and making it easy for that patient to be able to engage with you rather than having to maybe come to you, etc. It's about how they can engage you more effectively.
Cool. Yeah, so I'll take that last point first, if that's okay. So within the service, we've expanded the service over the last few months to include a care coordination function. So I think we really recognise there are so many symptoms of long COVID, and people are requiring lots of different interventions, and it is really difficult, isn't it, to keep a handle on everything. So there is care coordination within the service. People who are referred to the service have kind of a named person that's their coordinator, as it were. And they're regularly in touch with people to ensure, because if you've got multiple referrals going on, it can be quite tricky. So there's a key contact for each of the people who are referred. In terms of looking into the future, we are not doing any specific research ourselves within Kent and Medway, but we are very, very closely linked to the work that's going on across the southeast and also in London. I think because this is a new condition, there are multiple national and regional kind of scientific groups, and I can't remember communities of practice, I think they're calling them nowadays, but just opportunities for people who are providing the service or ICSs to get together and go, what are you doing? What are you doing? What's the most recent evidence? So we are right on top of the emerging evidence as it comes. I'm not in a position to comment clinically on leading to ME fibromyalgia, and actually I think the jury's out in terms of that, actually. And as I say, the most recent scientific conversation I was part of last week was actually our senior clinicians that are looking into this are very much looking at this as a recovery pathway rather than a long-term condition pathway. But we do recognise that we are seeing people with long COVID come forward where they have had those conditions in the past. So it may be that it's a recurrence of a previous long-term condition, particularly the ME and fibromyalgia cohort. And I think it's still not clear whether it's a resurgence of a prior condition or whether it's new and just specifically related to long COVID. We're really still learning, but we are keeping on top of the evidence for that. So in terms of voluntary and community sector, really closely linked to our voluntary and community sector colleagues, and particularly our social prescribing colleagues, in relation to providing peer support, thinking about support for carers, because we recognise that some people also have carer needs. Certainly in terms of linking to that local communities and rehabilitation. So we're linked into local gyms, for example, that are providing long COVID programmes of rehab. Still evolving and still working on many links, but our engagement colleagues are working with us to do some specific targeted bits of work. So from a Medway perspective, if you feel that there are some specific communities that we ought to perhaps be reaching into, then I'd be very happy to hear about that.
Thank you, Rachel. On your last point, I think your colleague made the same comments around talking to different elements of the voluntary sector, and sometimes people always aim at the health side of the voluntary sector, and they're not the only side you need to be speaking to. There are other ones like advice agencies, support groups, other things that actually don't engage in the health sector but actually deal with people that are coming with symptoms such as that. But there's also some really good networks. I know Martin, with my other hat, Martin and I sit on consortiums. It's about going to do a talk to your voluntary sector as a network, because there is consortiums here in Medway. There's round tables with partners that would then take it back to their organisations. Sometimes I think, and it isn't your fault, sometimes I think when we go out on items like this, we always go to, and it does happen sometimes with public health and others, we always go to those organisations that are health, orientated, like carers, etc., or who are right at the front line, so to speak. But we forget about the ones in the background that sometimes do the mechanics of dealing with them residents that you will never see. And I think if I'm not saying the media, but if you don't get in with those, it is a win-win situation for them to be able to educate residents and help residents too. So it isn't a lot of work for you guys to go and talk to your voluntary sector network to get them to then engage for you and to put that message out further. So, it's just another plea again, and it'd be good maybe the next time you come back for us to get an update on that. It's just another plea to please go out and engage with those vital partners, because there's hundreds of them, hundreds of groups out there that you can use one or two large networks here, like we've got the MVA, we've got others that could quickly put an email out to everybody and just to do that education pathway. Thank you, Chair.
No, thank you.
Thank you. That was a long question I understand that. The Director of Public Health, James, would like to have a...
Thanks, Chairman. Just to give members some assurance, and in particular, Councillor MacDonald, just around your points around how best we can engage with our community and ensure that they're aware of it. The National Institute for Health Research has got 19 individual studies out across the whole of the country, looking at all of the different aspects that you've just described in terms of long COVID, what the symptoms, what people may be or may not experiencing, how can we actually work better with them for them to understand what those things are, treatment programs, whatever else. So put about £39 million of funding into that at this moment in time, and these programs have been delivered at a number of different universities and institutions up and down the country. So, as we said, and what happens then is those findings get fed into the treatment services for them then to understand, right, actually we need to be now working with our communities like that. So just to reassure that there is a very robust research program in train, but it's a national thing with high-level clinical folk looking at all aspects of this, including the points that you referenced around the economic bits, Councillor Murray. So they're looking at that aspect as well, specific studies around that.
Thank you, James. Councillor Turpin.
Thank you, Chair. And thank you, Rachel, for this report. I had a couple of questions. One was on sort of the numbers you in the report, and I think you mentioned in your introduction that the numbers match the sort of demographics of the area. But sort of my understanding was that COVID did actually affect certain groups harder than others. So I just wanted to sort of make sure that actually the numbers accessing the service match that. And my other question is, within the pathway, it talks about a GP sort of referring a patient, and they may do bloods. So I'm just wondering if sort of, if a patient comes to them, they've had COVID, they've gone on to sort of, it seems like it's long COVID, but I'm just sort of concerned that if it's assumed, and they go into the service, does someone pick up, if the GP doesn't do the bloods, does someone within the service pick up bloods to make sure it's not something else? Thank you.
So ideally the GP would see someone first, assess them, rule out other conditions before they refer into the service. The service does have medical leadership though, that said. Once the full assessment has taken place, if there are any things that might be required, then they do go forward and do those additional investigations. So it's not purely on primary care to do that, although ideally they would do as much as they could before they referred to try and get the patient to the right place in the right time. In terms of matching the demographics, look, COVID is endemic now. Everybody's getting it. There are some suggestions that those with long-term conditions, for example, or those from areas of deprivation may be harder hit. Oh, sorry.
Sorry, through you, Chair. It just goes back to the point I made in relation to the work that's been done on this research. So just in case terms of that, Councillor Turpin, there's some specific studies looking at who gets long COVID and why. And it may well be that whilst we might expect, and I know the point that you're raising where we've looked at disadvantage in certain folk with underlying health conditions, are they more likely then to go on and get that? All of those questions, those research questions are being looked at now, because obviously it's only been a couple of years, unfortunately, for us to understand that long COVID is really quite a significant challenge. I'm not sure that the local service, because they haven't got that research capability, can answer those questions. I'm not trying to deflect the question. I'm just suggesting that there is that research that's in train that's going to give us the answers.
We do monitor, though, where patients are coming from in terms of deprivation and whether they have long-term conditions or not. And on the whole, the referrals are reflective of what we know.
You happy? Yep. Can I just ask, on page 20, 711, there's a little chart that gives us the percentages, initial specialist assessments by period of waiting times, comparing us, well, the South East, not even Medway, but the South East to England. Do you actually have the numbers? Because a high percentage of a very low number is not as good as, higher numbers in a different area. So by that, it's very difficult to judge what that actually means.
So ours is the biggest service in the South East. It caters for the largest population. I don't have the numbers on me, but I can provide them. This is I can't remember which month this data's from now, actually.
No, but if you could let us know the numbers.
I'm very happy to.
And how they compare to other areas, yeah. Especially if you can break it down for Medway, because that is why this committee's here, Medway.
Yeah, of course, no problem.
And my other problem is the lack of GPs in this area and how that must affect people getting to see their GP to start with before they can move on to your service. I know that's been mentioned before, but that is, well, very important for our area. And I don't see any other members' hands, so if we're happy, Councillor Purdy.
Thank you, Chair, and thank you, Rachel, for coming along and bringing this paper. Actually, I would just like to mention one thing. I think Councillor MacDonald has got a very good point when he says out in the community. I mean, we at Rock Avenue have that health group meeting there. And can you hear me all right? Okay, we have that, and a lot of people come along, and it's nice if they could just talk through, because they don't want to bother the doctor, but they have some of these symptoms, and they think, oh, I should be getting over them. So perhaps it would be rather nice if you could perhaps get someone to come along, not every week, but just once, so that they could discuss things. And that's just one place, but I do think that it's quite nice if you could be out in the public.
Yeah, I'm sure we'd be very happy to do that.
Come up Bluebell Hill and that would be super. Anyway, just to say, again, thank you very much for coming along and with the paper, and that we note the report.
Is that seconded? Thank you, Richard. And thank you very much.
Thank you.
Thank you. That takes us on to agenda item 6, the annual complaints and compliments report from Sandy Weaver. Welcome, Sandy.
Thank you. I'm sorry I'm coughing so much, and I haven't got COVID, just to reassure you all. This is a report that we have to produce by law. And
Sorry, Sandy, can you move your microphone?
Move it a bit? Is that better?
And
sorry. See, I'm short. Yep. No. Want to turn it up? No, should be okay. Okay. We cover how many complaints we had and what the issues were about and what lessons can be learned from those complaints. Cover also those complaints that have gone to the Ombudsman And then the compliments, because it's just as important to learn from what's going well. The opposite side of what isn't going well. And I think it's really important to learn from those compliments as well. I think that report's got lots of figures, and I won't go into all of them. And if anyone has any questions, I can try and answer them for you.
Okay, members, Councillor Murray.
Thank you, and thank you, as always, for a comprehensive report. I just wanted to, first of all, compliment the staff, because there are some really nice compliments. Sorry, Sandy, can you turn your...
Sorry.
There are some really nice compliments, and I think it's good to see those, and please pass on, praise and thanks to the staff. And I think when people give such detailed feedback, when they're happy with something, that does show that they've received a good service and that they feel that they want the staff to be recognised. However, in section 8 on communication, I know that the number of complaints about communication is going down. You've demonstrated that. But it does seem to me that it's a persistent area of complaint. And when we say, at the end of this report, one of the things we always say is all these things are used for learning. So I wonder, because it seems of all the problems that staff have to face when they receive complaints, and the financial ones are often driven by people's expectations that they wouldn't have to pay anything. There are complex reasons behind those complaints, but there isn't really an excuse for poor communication to be such a persistent area of complaint. And this kind of good manners stuff, people not introducing themselves. When someone's being cared for, or when their loved one is being cared for, feeling like they matter and feeling as if their views are really important, and you've said it's essential for good service delivery. I wonder, what learning has there been? And what sort of impact do you think it's had for this to be persistently returning? The other thing I wanted to ask about, there seem to be a lot more complaints in locality 1 than there are elsewhere. And I wonder if anyone's got anything to say about that, please.
Oh, thank you, Councillor Moore. I'll ask, I feel very loud. I'll answer these on behalf of Sandy. So communication has been an issue, and it's something that I see all the complaints that come through, and it's something that I see regularly. And I've been discussing that situation with customer contact so that we can look at how can we learn from the customer contact way of working to ensure that actually we are producing and providing responses. It would be dishonest of me to say that some of that isn't due to resource pressures, so where we have vacancies and so on and so forth. It does mean that on occasions where somebody says that they will respond, that actually something happens, they have to go out on a visit, and that falls by the wayside. It's not right, and Leanne would be able to say that something I do a weekly newsletter is something that I've been really pushing, is around how do we make sure that we're getting back to people. My personal view is that actually we may be a public-facing service, but customer service is as important as it is in any area of service delivery. But there is lots of work to do on that, and we know that is the case. So we have a working group in place at the moment that we're trying to keep quite small and not get too many people involved to think about how do we deal with things, the number of calls that we get, the demand that we're seeing at the moment, and the number of calls, it's very difficult to maintain that. So we're trying to think of different ways to manage that. We've introduced an online tool, but we're not sort of shouting about it at the moment because we want to see how we can get people to move across to that way of working, but also consider that not everybody can use that, and we need to sort of balance that. So we're looking at different options, and I'm hopeful that we'll see some changes coming through there. With regard to your question about locality 1 is our biggest pressured area. So if you talk about in terms of localities, locality 1 is where Medway Hospital sits. It's the largest number of care homes in that area. And so what we see is if there's a safeguarding for a care home, then that takes a lot of resource from the team to manage that. And at the moment, there's 5 in that locality. So again, it means that there's pressure for the staff to be able to manage things. There's a piece of work going on at the moment about right-sizing adult social care, so what is it we actually need, what does the resource look like, and that's something that Leanne is really sort of pushing forward for us to deal with. And I don't just mean from a social work perspective. Actually, you talked about finance earlier on. We know that we've got the care reforms coming. We know there's going to be an increase in demand, so we've got to look at ways of managing that. But recruitment is a struggle. We are really seeing some challenges, not in social workers specifically. We have got vacancies, but in other areas of the council, which, if you talk about financial assessments as an example, so it's all sort of, it's a challenging time at the moment, and the team are doing really well, but it does mean that we can't always deliver the service that we'd want to.
It's a bit tangential, Chair, but if I can come back, please, and thank you for your answers, Jackie. I just, whether the complaints are actually used when you're, developing better communication, it would be helpful to know that. And on, I was talking about this today, what will effectively be a new workforce, won't it, the financial assessors? I wonder if, when we get to the programme, to the work programme, there's anything coming forward about how the project manager is getting on with planning for the cap on social care and what's happening. I'm not saying I won't necessarily want an answer tonight, but I think, that workforce is going to be critical to managing the new legislation, isn't it? And it's not something we're brilliant at now. So the recruitment and training of the new workforce to help manage that process is critical. So I think at some point, knowing how everyone's getting on would be helpful, please.
So if I just respond to the lessons learned, I think, have we done it well in the past? Probably not as much as I'd like to. The principal social worker is actually really picking that up about that embedding lunchtime learning sessions, training sessions. So, I think with Michelle in place, that will make a difference. I brought a paper about the care reforms to the last meeting. The fair cost of care exercise is due to be completed by the 14th of March, the first draft. So we've now started around the reaching out to providers about self-funders so that we can start understanding numbers. So I would like to think by December we'll be in a good position to say this is where we are, what it looks like and the workforce we need.
Thank you. Councillor Turpin.
Thank you, Chair. My questions that I had from reading through the report are actually all been asked by Councillor Murray, pretty much. The only one I did want to sort of go into that I asked sort of at children and young people, actually, when we had this report, was regarding the compliments, because sort of reading through those, they are very heartwarming, actually, just to read the impact on people's lives and, how much the service means to them and how much, it's helping them and their family members. So I just wanted to sort of ask how that is shared amongst the teams, because I think it's really important to not only sort of talk about complaints, but also learning from compliments and how other staff are doing things and to sort of, boost morale. But also I think, you learn a lot from, your colleague who's done something really good and think, oh yeah, that's how I can do things. So is it sort of actually programmed into staff time? Thank you.
Absolutely is. So, and I think it's become more prominent. So when I started in post, when I met the teams, and I know it's been nearly 2 years now, I said, let me know and include me in any compliments, and I see all the complaints as well. So what happens is a compliment will come through, they'll send it in, copy it into Sandy, but they copy it into me, and I then immediately respond to the person that's being complimented, I can't think what the word is, and their manager to say, actually, this is fantastic, well done, this is the impact it has. We do a weekly newsletter, so we then pick them in to put them into the newsletter. So we'll do a shout out to, well done to, isn't this a great piece of work? We had one recently where a social worker has really got to know a resident and had noticed over the last few weeks they weren't themselves, came quite concerned, went round, knocked at the door, found the door open, went in and he wasn't well. They stayed with him, the social worker and the social care officer stayed with that man until 3 o'clock in the morning and went until the ambulance arrived because they didn't want to leave him on his own. So, you know, took out that their time. We made a very big deal of that, you know. So we want people to understand because it is really quick to, people are very quick to complain, and I've just sort of reflected on the one about the carers not introducing themselves. Some of the complaints we get are actually about the providers. So they may have complained to the home care provider or the residential care provider and they're not comfortable with the response, so then they come to us, so we then liaise with the care providers. And in that circumstance, when they talk about carers, the likelihood it would have been a domiciliary care provider. So then we work with them to think about how we do things differently as well. So yeah, it's become a big deal. We've created a shout out page on Microsoft Teams, trying to get people to put in things and go, you know, well done to so and so. Yeah, we do.
Thank you. Thank you, Jackie. Any other member? No? No. Thank you, Sandy, as well. Over to you, Councillor Purdy.
Thank you, Sandy. Thank you for this. Actually, I think this was a really well-balanced paper because we had lots of people saying that we've done things well and we have people saying that we're not doing it quite so good. And I think, and maybe Councillor Murray won't agree with me, but we do learn from our mistakes. And I think some of this is coming through. So I think it's a pretty good balance paper and well done to everybody. And I think we all want to send our thanks to the staff because it's not an easy job, is it? You're damned if you do and you're damned if you don't. Anyway, I just move that thank you for coming along as usual, Sandy, and you, Michelle, and thank you for the paper. And we just note the report.
Thank you. And Richard, second. Thank you, Michelle, as well. Thank you. Right, members, that takes us on to agenda item 7, the Council Plan Performance Monitoring Report and Risk Summary, Quarter 1. Leanne will introduce and lead on this. Leanne, over to you.
Thank you, Chair. I think the easiest way to deal with this this evening is to get Jackie just to deal with any red indicators and then open it up for questions, Chair, just so that we're dealing with the ones that are not as they should be. Thank you.
Thank you. We do this quite regularly, but as in the complaints and compliments, all the green ones, I'm sure all of the committee will compliment all the teams that produce the work that goes into those. So thank you. Over to you.
Thank you very much. So on the paper, you'll see at the moment there is one red and there is an amber. But I'll concentrate on the red, and obviously if anybody's got any queries about the amber to ask me. So the red is the number of people who have a primary support reason of a learning disability who live in their own home or with their family. This is something that we've sort of had some challenges with for a period of time, and actually in the last 3 months there's been some work carried out specifically around this area to ensure that we are doing what we should be to enable and support people to live at home independently if they have a learning disability. What we've identified is that an area of difficulty is around, are we recording things appropriately? Now that doesn't mean that people aren't actually using the IT system correctly. It's around when we complete our annual reviews, are we asking the right questions and then completing the information? And actually, are we doing our annual reviews correctly? Because that's where we would gather that information. The report mentions that we obviously prioritise assessments and safeguarding, and I mentioned earlier on around the complaints that we do have some challenges around the demand that's coming into adult social care, and if there is obviously a safeguarding issue, then that will take priority over completing a review. So we've got a plan in place to actually approach the reviews and make sure that we're getting on top of those, and as we do that, we will be able to then identify people who are living independently at home with a learning disability and ensure that we're recording the information correctly. I think it's always been a challenge. It's very quick to stop doing reviews in these circumstances, but it is a statutory duty, and that's why we're pushing forward with that.
Thank you. Any members? Thank you. Councillor Murray.
Yeah, thank you. I mean, given the challenges, I think everyone's doing pretty well to stay on target with these measures. You know, that is quite a significant achievement, especially as I don't think we really know what the social care precept is going to be. And it might be 0 the way things are going. So that will be another challenge. But I think with the adults with learning disability, is there a kind of supply issue about places that people can transition to as they get older and might need, you know, might want more independent living? It may be that their family carers are getting older and less likely to cope. And although, you know, we talk about a lot about extra care for older people, we don't talk much about the sort of equivalent in supported living for disabled people. And we were due, weren't we, to have a briefing on supported housing, which was sort of postponed, and I haven't heard anything much about it. And I wonder, for members anyway, if managing to sort of reinvigorate or get that briefing would give us a greater understanding of why this is a persistently red target. It's been like this for years, isn't it? I mean, this, you know, really years. So I think it's not so much about worrying about the fact that the target's red, it's more moving to the reasons that are holding it down.
So, is there the right provision? Probably not. I think for people who are in their sort of earlier, I can say this, their earlier time of life, they can moving into supported living is a good thing. For people who maybe have been, you know, and we see this where somebody's been living with their family for a long time, something happens where mum or dad go into hospital or somebody passes away, we end up in a situation with a Medway resident that has a learning disability or a physical disability that suddenly falls into the adult social care system. And if we were looking at do we have the right provision then, probably, as I say, I probably don't think we have. We've started conversations with our extra care providers recently to say to them, actually, would they consider taking people under the age of 55? We have got one who is looking at that at the moment. They want to consult with their residents because obviously it will bring a sort of different way of and a different group of people into the into that facility. And we're also discussing with commissioning at the moment about what's needed on the long term. So we've drafted our I've got the word now, accommodation strategy, and we're just doing that analysis about what is needed going forward in the future. If from a residential care perspective, I mean, we always try to look at, and I know that's not about people living independently, but if we're talking about it in the round, from a residential care perspective, that's always the least, you know, the option that we try not to look at. If that is the case, then again, that is an issue for the number of placements in Medway, and we do tend to have to look outside of the area in that case. So it's something that we know needs to be resolved. being part of the Learning Disability and Autism Collaborative with Kent, actually, I think will help us, because we're seeing that across the board and how we work together to deliver better services. And with the programme director on board now, who's very passionate, I think is the word, to move things and get things changed in, and Medway and KCC working together, we will see some changes. I think the other thing is about managing expectations, and making sure, while we want people to remain independent, it's the right people. And we have to consider that sometimes moving into residential care will be the best place for somebody to be, as opposed to in the community. So it's a sort of a mountain of things, really.
Please, Chair. You know, there are opportunities, I think, to work better and smarter across the council about this, aren't there? It doesn't feature very largely in the housing strategy, and the situation with the local plan now, sort of back to the drawing board situation, does mean that there's an opening there to put in some provision for this input. You know, it's a really important group of people, isn't it? You know, that there's nothing worse for a family than thinking that they're not able to secure a safe future for a learning disabled or physically disabled child when they are themselves no longer able to provide the care that they once did. That's a really stressful and upsetting situation to be in. And I think, you know, we know where this group of people are, and broadly we know, working with the NHS, certainly, how old they are, you know, how so we can quantify how their needs could be met. And I think doing that within the planning system is important for two reasons. It's important so that actually we do start to get the kind of provision that we need, and we get it within area and get some efficiencies by doing so. And it's important in terms of saying that the profile of this group of people in our community is the same as everybody else. You know, we'll talk a lot about, you know, how many dwellings we might need for single people, how many dwellings we might need for families, but we don't talk enough in those technical areas of the council about this group of people. And I think by coincidence, and in some ways an unwelcome coincidence, there is an opportunity to do that a bit more at the moment.
Sorry, Jackie, Leanne wanted to come in.
I think the point that you've raised, Councillor Murray, is very interesting, because you'll know that Ofsted visited us recently for a monitoring visit on our 0 to 25, and while the findings are embargoed, they did take the opportunity to discuss exactly what you are raising around our transitions, and were they strong enough in Medway? So from our children's services into adults, and they went that one step further. How are we preparing families for the lifespan, the life chances, experiences of their children, and what that would look like as adults? So you know, we will take that on board, obviously, and Jackie's already doing some of that work around transitions, but it goes further. You're quite right, it's a systems issue. How does housing contribute, you know, et cetera. So it's around, Children's has done a lot of work around the sufficiency strategy for children. We need one in this area, and I think that's where the work that Jackie's talking about will eventually take us. So, yeah.
Jackie, did you want to add?
Please, yeah. So I just wanted to give a little bit of assurance, really, and I should have mentioned this. So actually working with housing, we've got 2 properties that are going to be opening in Borough Road in Gillingham, where we're going to have 7 supported living flats. And that was a really, you know, that was that interaction with housing and adult social care, and them saying to us, this is an opportunity, do you want to bring that up? Actually, what that's led to, and also discussions with other areas in the council, and we've got our second meeting on Friday, is a cross-directorate working group, so housing, myself, children's services, other colleagues in the council, we're working together to say, actually, what do we need to do to be improving this situation for people around supported accommodation, supported living, because for us it isn't just about the service that we provide. It's you can move somebody into supported living and really get them into independence, and we see that in shared lives as well. But if we then can't move them into their own independent living, everything gets blocked. So not only are we looking at what sort of provision is needed in Medway, it's how do we then provide people with a house, flat or accommodation after. So say the second meeting takes place Friday, so that has started to be looked at. And then just with regards to planning, Sue, who is the head of Adult Partnership Commissioning, actually meets very regularly with the planning team, because we're sort of saying, you know, we really need accommodation and in Medway. The challenge we have at the moment is when somebody comes forward to say we want to build a residential home in Medway, they want to build a residential home that is a standard residential home, and actually we need residential dementia or nursing dementia beds. So people start to pull out then. So that working with Dave around, you know, how do we make sure that when people come to us, we're talking about what's needed, you know, those conversations are taking place as well.
Chair, and just sort of sharing a bit really, I'm pleased to hear that, because that visibility is important. And, you know, people around the table might have seen there's a sitcom on at the moment about some people with Down syndrome. And it's very good to see that on mainstream broadcast media. And in fact, I think something like 70% of the production and writing team are disabled. And I was listening to a podcast over the weekend. And one of the things that everybody said, obviously they're receiving a lot of praise and plaudits for getting as far as they've done, which is great. But one of the things that they all said, but the director vocalised it was, he said, don't run away with the idea that I think about my disability all the time. I get up in the morning like everyone else, and I think about what I'm going to do during the day, and I think about where I'm going to go on holiday. And his disability is cerebral palsy with actually a very unstable leg. And it's not until my knee gives a twinge that I think about being disabled. And I think that's probably the case for lots of people, but we're doing an awful lot to pigeonhole people. So I'm really pleased about the Borough Road development. I hadn't heard about that, and I'm sure there'll be other members around the table who'd be interested in seeing and hearing about that. But like I say, there's an opportunity to, as Leanne said, get this into the system wide. And I think once that happens, we'll be in a stronger position to be able to say, well, actually, you know, your lifetime housing is as important as anybody else's, and we've planned for it, and that will be really good.
Thank you. So it's not on here, but it actually aligns with this. So one of the other performance indicators is around people with a learning disability and supporting them into employment. And we've been working really closely with Dan Ratcliffe and his team and commissioning to actually have, we've now got 2 people working in Jenny Bartlett's team who are actually dedicated to supporting people into employment with learning disabilities and mental health, because you're absolutely that reason. There's so many people that, you know, live a normal daily life. I'm also liaising with BMIX, and I've got BMIX involved, so working with those as well. So just to give you some assurance. I'm not saying for a minute we've got a lot to do, but we're on that path.
Okay, thank you. As there are no other questions from members, if I can just go to page 42 and the recommendations. If you don't mind, Wendy, I will. Members are asked to consider Q1 performance against the measures, and we're asked to note the amended strategic risk summary as Appendix 2. Under 8.2, members are asked to look at SR 52, which we have looked at before, and before we voted to stay with the status quo. Are members still happy with that? Yes, thank you. So if you don't mind, I've taken your job. If that can be seconded, please. Right, thank you. Is that agreed? Agreed, thank you. That takes us on to the work programme, agenda item 8. So over to Michael.
Okay, thank you, Chairman. I haven't got anything to add to the report, but happy to answer any questions from members. Thank you.
Councillor Murray.
Yeah, I mean, thank you. Obviously, you know, we've had a few things where reports haven't been ready and people have needed more time to come forward. I think at this point I would definitely like to thank everyone that's been involved in the GP task group so far. There's some really good work that's gone on there, and I'm very confident that we'll be able to come forward with some good recommendations that will impact onto the ICB's overall plan. It's been a really good opportunity to look at some good practice and to be honest and frank about the things that are going wrong. I wanted to ask about our mental health trust partners. It was World Mental Health Day yesterday, as people will know. And actually, local broadcast media, again, did a very good job on, I think, Radio Kent, for example, had things on all day talking about mental health and signposting people to different things, having successes. I don't feel in this last municipal year and a bit before that we've had enough engagement either with KMPT or NELFT. And one of the things that has become very clear, and it does affect us here because of transition, is the increasingly high waiting times for people to see CAMS that actually can lead people to transition into adult mental health before they've even managed to see anybody in children's mental health. And I think I would like to see NELFT back here, and I'd like to see KMT, and it might be helpful to see them both on the same night to see how they're working together. You know, when we had KMPT last time, we heard about a lot of changes, a lot of management movement, a lot of plans. Obviously, we've got the Gillingham facility now, and I just don't feel that we've had an opportunity to really focus on what they're doing and to try to find out why the waiting list, you know, there's never been a greater demand, actually, in the last 25 years than there is now for help with mental ill health. And the trusts, I don't think, as things stand at the moment, are doing as good a job for the people that we represent as we would all like them to be doing. So I wonder if there is a gap to have them back at some point before the end of this municipal year.
Well, I'm happy to put them on the work programme. It would be helpful if you attended the pre-agenda so that we could have those discussions there, because that is the place for those. But I'm quite happy to put that on the agenda to talk about at the next pre-agenda, or for it to go on the work programme. James, you wanted to come in.
Thank you, Chair, and thanks, Councillor Murray. I think we were all quite impressed, I would suggest, about the work that we did yesterday to launch World Mental Health Day and the fantastic sort of uptake with people coming into the dockyard yesterday. I think your specific bit around the mental health, so we're talking about the NELF, so the children's bit. Listen, I think we all in this chamber, I know members have shared their concerns about the impact and of the pandemic and other issues on our children and young people, and you raised some really valid points. I'm just minded of a couple of things, and it may well be that to get the benefits out of getting them into this space, so mightn't be more helpful to try and get a member briefing in terms of getting an understanding as to what they're doing, because this is specifically about the NELF element and the CAMS contract, because there's a lot of work going on in that space at this moment in time, in particular with the work that we're doing across Kent and Medway with the Integrated Care Board to look at those children's services, to look at how we can maximise the benefits for them, because that's a bit more of a holistic affair, and to plan forward, because we probably just need to, because there's lots of, I'm not trying to dissuade members from looking at this. I think it's an extremely important issue, but I'm just looking at timing so that you actually get the benefits of being able to scrutinise the work that they've done in a way which will give value back. I'm not saying that it won't give value back, but to influence changes to their actual practice. So if we perhaps go for a member briefing and we can get them to do that for us, to give you an update as to activity and what's happening in that space, and then perhaps we can work to schedule in a time, because I know you want to get them in a municipal year, but I'm sort of thinking that that might be fine, but you might not get the benefits from the interaction with them based on where they are with their sort of planning cycles, because there's a whole range of issues going on with, I think I can't say too much, but the contractual renegotiations and things like that.
Going to raise that, James, thank you. It would be helpful to have a briefing. It's always helpful to have a briefing, because I think, more members than sit on health or children's would be interested in this, because it's a very prevalent and prescient issue that's there at the moment, and I understand the points that you're making. I think I would like, or the Labour Group would like, us to try and do both. I think a briefing would be useful, and it would be good to have them here. And the reason I say that about NELF particularly, and you've just alluded to it, yes, they must be coming up to the next lot of commissioning. And the last time that they were commissioned, the transition period between the old provider and them taking over was very, very poorly managed indeed. And when Breed was here 3 years ago, she admitted that herself, that they had people falling through the gap. They didn't have a robust transition plan in place. And I would particularly like to ask them about that and make sure that the same thing isn't going to happen again, because for those people in the eating disorder service, it really was a terrible time. And they were frank about that here. And if they're intending to bid again, I would like to know, what they've learned from that and how they're going to stop that happening. So an overall briefing, yes, I think lots of people would benefit from that, and if their casework is anything like mine, there'll be lots of members who've got those kinds of worries. But if we can see them here, I would like to do that.
Okay, so are members happy that first we arrange a briefing and it would make sense that we ask them, that it goes on the work programme after that briefing, if we're not content? Yep, the members agree with that? Right.
I'm going to go on about CAMS. I think that CAMS has been, but I believe that is being looked at, and there are going to be different streams, if I'm right, James, isn't there, of CAMS, and that, they're going to give them new fancy names, but it's going to be, so I feel, but I think that would come to children's, wouldn't it, rather than come to here, because, we don't want to go down that line that we've gone down with CAMS again, but for my little knowledge, I understand that is all being looked at.
That's correct, and that's why I'm just looking at the whole timing, because from my perspective, if you've got, it doesn't matter whether it's this provider or another, if they're coming into a commercial position, then clearly that we've just got to be mindful of how we manage that. But it will go through children's, clearly it will do that. But why don't we work it through, as we've agreed, Chair, to get a briefing note, then we can look at the timetable. If members want further information, clearly it's asked, you can call them in and you can have a conversation with them as set out.
like that things are being done. We're not sitting on our laurels, are we? Because I was a little concerned about Ruby Ward, but that's still in the air, and I would like to see something about that. Will that come back as well, James, with the briefing?
So Ruby Ward would be the adults, so that would be KMPT, and clearly I think when they came and members signed off the move, it was with the caveat that they would come back and tell us how things are happening, so I'm pretty sure that we can get them back in due course to get that planned into the work programme.
Chairman, that issue is in the work programme. It's in the date to be confirmed section.
Sorry?
That issue is in the work programme, in the date to be determined section. Yes, I think the idea was that once the new unit was up and running, you would ask them to come back a few months after that to review how things have got on.
We'll be coming up for an election soon, and I think that we would like to have more information before the election. Other members. Anyway, I'll leave that in the air and I'll talk about it with David.
Right, thank you. Over to you for the recommendations. Or is it back to Michael?
All members agree the work programme and a briefing on mental health? Yeah? I think that's about sums it up, and I might get some information about Ruby Ward eventually.
Right. Yep. And we approved the proposed work programme. Okay. And is that seconded? Thank you. Thank you, members. Thank you.